each individual patient how the respective connection is and how the respective innervation pattern is. And the same is for sensory. So you have the dermatose that you all know when you treat spinal patients. And if you turn this into a more plexus and more peripheral nerve-based view of the things, you will find these innervation patterns that, of course, are highly individual too. But you know, like the target muscles for C5 is deltoid and C6 is bicep and so on, you will find similarities for the sensory innervations. So it makes sense, and this goes also for us experienced neurosurgeons and brachial plexus surgeons. So go back to the books once in a while just to reassure and reconfirm of that what you know and what you think is true is really true. Or maybe you will find cases that you need to go through all over because nothing is the way that you thought it was. As maybe you've heard of the so-called prefixed plexus. So this means it doesn't start at C5 and goes to T1, but prefixed means it starts at C4 and goes to C8. As well as postfix means that it doesn't start at C5, but at C6 and goes down to T1, T2. So these are things that you will encounter, and these are things that you need to keep in mind to be able to treat your patient properly. So let's start with the supraclavicular approach. As we had heard before, even here you need friends. So if the patient is laid on the OR table, usually we tilt the head slightly to the opposite side, and then we identify, of course, the clavicle, and we identify the external border of the sternocleidomastoid muscle. These are the two structures that are, you know, elementary for getting to the plexus, and this is where the incision usually is placed. So this is from the book of Mario and Roberto. So this is medial, this is lateral, this is cranial, and this is caudal. And what you see is that you have the sternocleidomastoid muscle, and when you open up, the first thing that you find is the platysm. And you open that up, you will find the external border of the sternocleidoid muscle. And you have the external jugular artery, vein. And of course, the cervical plexus, not to confuse with the brachial plexus. Some people say cervical brachial plexus. This is something that is not existing. So they're two different entities. So first step is open the platysm, find the external border of the sternocleidoid muscle, and open up the cervical fascia. And the next muscle that will lead your way to the plexus is orthogonal to the sternocleidoid muscle. It's the omohyoid muscle. So this is important in two regards. First, to guide you to the plexus. And second, if you follow it distally, you will be able to follow up the suprascapular nerve, which, as we saw before, is part of the brachial plexus. So this is already the deep fascia open, and you will find this fat body that is covering and protecting your plexus, is helping the plexus to glide. So you should be very careful with it and not cauterize it as much as you can, but just detach it on the medial border and then flip it around to preserve it, and later on to be able to use it again to cover the plexus. Once you have identified the omohyoid muscle, you go next step, as the authors did here, and you pull it upwards, you pull it to open up the space. And then the next muscle you will find is, so this is again a sternocleidoid muscle. You see both scalene muscles, the anterior scalene and the middle scalene muscle. And what makes you surely identify the anterior scalene muscle is that the phrenic nerve is running along it. And the easiest way to be sure if this is not a vessel or not a lymphatic duct or whatever is to use intra-op stimulation. So once you identify the anterior scalene muscle and you see a nerve and you stimulate and you have diaphragm contractions, or if your anesthesiologist starts to complain, you know that you are right. This is so the phrenic nerve and the anterior scalene muscles are your next friends, because it's easy to find it. Usually going down to the clavicle, you will easily find it. If you go cranially, which is this direction, you will end up in C5, and you will end up at the lateral border of anterior scalene muscle and the middle scalene muscle. So this is what you call the interscalene triangle. This is actually it. This is actually it. So from there on, you know that you're in the level, in the surgical plane in which you should find the plexus. So from that on, well, you need to be careful and meticulous all the time, but from that on, you need to be even more meticulous and more prepared to encounter nerves. So this is taking you to the next step. We see that the structures have already been dissected out. And as you can see, as I said before, this is what you find first. This is what you will see first. These are the trunks. So usually you don't start operating or dissecting proximally where you find the spinal nerves, as you see as C5. So we came all the way up from the phrenic nerve and we found C5. Then we go down and we see the superior trunk that is formed by C6 and C5. And the first branch of the supraclavicular plexus of the superior trunk is the suprascapular nerve, which is this one. And the branching pattern is different, or can be different. You have an anterior and you have a posterior division. Then you go more caudal and more medial, and you will find C7 and the middle trunk. Then you move like climbing a ladder. You take the next step, and you will find the inferior trunk with C8 and T1. And of course, and you know when you're headed caudally enough, when you find the subclavian artery, which is of course easy to identify or to palpate. And I'm talking about normal anatomy now. I'm not talking about brachial plexus injuries. This is something that maybe you would find when operating on a TOS. So you have clear anatomical structures guiding your way. So sternocleidoid muscle, mastoid muscle, omohyoid muscle, which is rejected, anterior scalene muscle, phrenic nerve. You find the plexus, you find the middle scalene muscle, you find the subclavian artery, and you have the clavicle. And from there on, you will develop all these plexus structures. And as you going back to this one, as you find here, the first real plexus structures that you will see are the trunks, are not the spinal nerves usually. So this is video from Mariano. You see the muscle, you see the phrenic nerve, you see the, so the phrenic nerve is now grabbed, you see the anterior scalene muscle, and you see that what in the next videos will become the plexus. You see here the anterior scalene, the sternocleidomastoid muscle retracted, so to open up the view on the plexus, which of course in surgical reality you would not do, to remove the sternocleidomastoid muscle. So next video, zooming in, you see phrenic nerve, anterior scalene muscle, you see the superior trunk, and not right visible now is the suprascapular nerve will exit here, and somewhere here down will be the clavicle. And this is telefixed cadaver. So you see the difference to the fresh frozen or to reality. So now, once you saw and once you detected the plexus, you want to know the exact individual anatomy. So now it starts that you will find and go up for C5, following it all the way up to the foramen, same for C6, for C7, and especially in TOS, you want to know what about the inferior trunk, which is the most affected nerve structure during in TOS. In this case, the authors, as you can see here, detached the anterior scalene muscle. So you see how close, this is the internal jugular vein. So you see how close all the structures are. Again, phrenic nerve, this is the pleural cupola. So you're on the lung, you need to be aware of that too. So it's a very interesting, a very beautiful region, but it's also a region that you can cause damage and severe damage. So you need to keep in mind that you're working in a very delicate field. Once again, shown in the video, the individual structures. So you see here the suprascapular nerve, superior trunk, phrenic nerve. Posterior division, middle trunk appearing. This is middle trunk. Fantastic voice of Mariano. And then you will see the inferior trunk, and down here are the vessels. Is the subclavian artery. Okay. So now we dissected out all the suprascapular plexus, and believe me, it can appear and seem very easy, especially if you have these fantastic images that I just tried to show you. But to be able to do this in reality is that you need to respect the layers that nature offers you. And once you do that, first, you can do little harm. And second, you will be very straight forward and very clean to find and dissect out the brachial plexus. So the second is the infraclavicular space. And again, I apologize for the quality of the scanners. So this is deltoid muscle. This is the pec major, and this is the fossa. So now here, the pec major is retracted, the deltoid is retracted, and what you find next is what is here marked with the loop is the pec minor. And already underneath, you see this fat body that is covering, again, the infraclavicular plexus, in the same way as the supraclavicular plexus is covered by the fat body. And again, this is something that you definitely need to preserve. Don't count with, don't take it out. Just detach it, flip it medially or wherever you want, but don't leave it pedicled, don't kill it. So again, the video, so pec major is marked, pec minor is now reflected. And once you're underneath the pec minor, you're on the plexus. So this is what you know. So you can move quite fast once you're above pec minor level. Once you get underneath pec minor level, you need to be very careful because then you will be in the infraclavicular plexus. Yeah. Okay. So again, here, as you see, pec minor is detached. It's flipped medially with the preservation of the pectoral nerves. And once you flip it back, you will find, again, your three infraclavicular friends, which is lateral cord, posterior cord, medial cord. So again, supraclavicularly, you have the three friends of yours are the three trunks. Infraclavicular, your three friends are the cords. And from there on, you can develop the divisions, you can develop the terminal branches. But if you, once you identify the cords, you will be safe and you will understand what's the deal. And you need to know that the names of the cords derive from their position to the axillary or subclavian artery. So the lateral cord is lateral to it, the medial, and the posterior. It's very simple, but sometimes these simple things save your, save you and your patients when you remember it. And intraoperatively, especially in traumatic cases, see, okay, where's the vessel and where are my cords? So that's the way when
when
you're not sure to identify the structures. So once again, this is pec minor removed. You see the lateral fascicle, which is always the first one that you encounter, and you see the vessel here. So this is muscle. I will stop it here. So lateral cord, musculocutaneous part, and the part that goes to the median nerve. And this is the artery. So we are lateral to the artery, okay? So lateral fascicle. And as you can see here, the musculocutaneous nerve, which in reconstruction is crucial because you want to give back arm flexion. That's the only nerve that leaves the compartment in which the other vessels and nerves run in, but it enters the brachioradial muscle. As you can see here. So this is how you identify the MCN. I'm sorry, the coracobrachial muscles. That's how you identify the MCN. It's entering the muscle, and then you know it's the MCN. Okay, keep that in mind. It will help you a lot to identify the nerve. Moving to our next structures. So we identified lateral fascicle. We identified MCN. We identified the median aspect of the MCN. Again, MCN, median nerve, and this is the artery. Okay. And here you see the medial fascicle, medial cord. Yeah. And this is just by flipping back the pec minor. Okay. So, of course, we want to know all the structures. So that's why we retract the lateral cord, we retract the arteries, and then we see the posterior cord, this one, that goes to the quadrangular space, which is the axillary nerve, is the deepest nerve of the infraclavicular plexus. And we see the radial nerve that goes down further down the arm. So with that, and you see there's not a lot of manipulation done, you will find and identify your structures. Once more, posterior fascicle, axillary nerve, radial nerve, and just by retracting gently the structures. So this is what I wanted to show you with this brief introduction to brachial plexus anatomy. And it's worthwhile to get into books. And if you have any chance to get your hands on cadavers, just go for it. And this is the team that I'm blessed to work with. And thank you very much for your attention.
So, thank you very much, Christian. Excellent presentation, excellent overview of the brachial plexus anatomy. We have another speaker, distinguished Dottoressa Debora Garozzo, who will present us a very important topic, thoracic outlet syndrome. So, Debora, please, the floor is yours.
Hi, can you see my screen?
Yes.
So first of all, hello again, everyone. I think Christian has given an excellent overview on brachial plexus anatomy, and this is going to be extremely useful for me during my presentation. So I'm going to talk about a very controversial entity in peripheral nerve surgery, which is the thoracic outlet syndrome. It has a very uncommon incidence that I believe is very likely to be underestimated, and it's an entrapment syndrome prevalent in female patients that is related to a compression on the neurovascular bundle for the upper extremity, which is consequent to a narrowing of the passageway between the cervical spine and the axilla, due to anatomical anomalies which are responsible of causing a further narrowing of this space, or factors that might be responsible of altering the ratio between the container and the content. Now let's start to talk about bone anomalies. Bone anomalies are represented by cervical ribs, which are actually mostly incidental findings, absolutely not related to triggering symptoms in many patients. And they might be sometimes associated with anomaly of the brachial plexus, like a pre or a post-fixed plexus, as Christian already mentioned during his talk. We may also have anomalous fibrous bands, mainly originating from the cervical rib, and we can also have muscle anomalies. In particular, I have to say, probably the most significant muscle anomalies are those related to the insertion of the middle scalene muscle, especially when there is also the presence of a bone anomaly. Textbooks usually do not mention the presence of vascular anomalies, but I have to say this is something which has been quite regular in my surgical experience, because I think this actually triggers the presence of a neurovascular conflict, a concept that we neurosurgeons are quite familiar with. And then when we talk about the factors altering the container and the content ratio, we have to mention, first of all, that TOS should be considered as a dynamic compression of the neurovascular bundle for the upper extremity, which is consequent to a muscle imbalance in the shoulder girdle triggered by factors that might be constitutional, postural, or professional. Concerning the constitutional factors, I think all of us that deal with cases of TOS know that most of the female patients present a typical phenotype that I call the Modigliani phenotype as an homage to the Italian painter. These are ladies with a long and slender neck, narrow shoulders, and especially heavy breasts. And this is one of the reasons why I usually very often strongly recommend a reductive mastoplasty for these ladies, especially if I see them in the initial stage of the syndrome. But there are also other factors that may predispose to the development of a TOS. Postural factors. So, for instance, we know that musicians, like a musician playing the flute or the violin, may be particularly predisposed to develop this muscle imbalance. Patients that have a past medical history of whiplash injury, and something which I have observed recently, a past medical history of cervical spine surgery. Now, when we talk about the clinical presentation, we know that it varies depending on the structures of the neurovascular bundle, which are mostly affected by the compression. We have a quite negligible percentage of patients that present vascular forms, and then the vast majority of patients, up to 95%, are those that present a neurogenic TOS. Neurogenic TOS, we know, may be divided into two subgroups. We have a group, which is the minority, where patients progressively develop a thenar and hypophenar muscle waste, the so-called Gilead-Sumner hand. These are the cases where the diagnosis is actually quite straightforward and also supported by electrodiagnostic studies. But the main problem is that related to the diagnosis of the big group of these patients, those that do not present neurological deficits, and when the syndrome is only manifest because we have the so-called irritative symptoms, pain and paresthesias radiating on the upper extremity. Now, the TOS clinical form without deficit is actually a very controversial entity, because we have no anatomical anomaly, no neurological deficit, no electrodiagnostic evidence, as I'm going to show you in a while. And therefore, the diagnosis may be actually quite tricky, and especially for those who are unexperienced. And this is also the reason why this is a controversial entity, which has even been not recognized by many neurologists and neurosurgeons, and is one of also the reasons why, unfortunately, these patients are very often misdiagnosed. Now, TOS without neurological deficit is unfortunately burdened by a lot of misconceptions that you see listed in this slide here, and which I will try to demystify in the next slides. Now, first of all, I would like you to listen to the testimony of this patient of mine, because I think it's very significant of the ordeal that many of these patients have to go through before they eventually achieve a diagnosis.
Sorry, Debora, we can't hear it.
So I think there is a problem with the audio of the video. What I just wanted to you to focus on is that this is a patient that came to my observation 3 years after she had started to have symptoms, and she was eventually diagnosed as affected by depression. Now, the difficulty of this diagnosis actually often results in the patient is misdiagnosed and very often treated as depressed or affected by conversion disorder. Now, in order to show you what is the diagnostic workup that I do to be able to diagnose patients with a TOS without neurological deficits, I'm going to briefly present the experience I had over the first 3 years after I relocated in Dubai, when I was referred approximately 79 patients complaining of pain and paresthesias on the upper extremity. And out of these patients, where there was no evidence of a discogenic etiology of the symptoms, I diagnosed 46 neurogenic TOS. It's interesting to note that the majority of them were ladies, primary cases with a very long dating history. I ended up operating on patients who had been in pain for over 10 years. Whereas in the group of the male patients, there were quite a few cases of secondary TOS, and the clinical history for male patients was significantly shorter. In my series, in the first 3 years in Dubai, there was only one patient with a type 4 of Gruber's classification for cervical rib, and only one case where there were neurological deficit with a progressive development of thenar and hypothenar muscle waste. All the other cases were patients where the TOS manifested itself with symptoms not associated with neurological deficits. And in order to get the diagnosis, I focus on the past medical history, the clinical presentation, and in particular the distribution of pain, the neurological examination, and then, of course, the investigations I'll show you later. So going back to the patient that you saw a few slides before, this patient has a past medical history of a twin pregnancy with a consequent massive increase of breast during lactation, and her symptoms started exactly after delivery. Now, the distribution of pain in patients with TOS is very typical. Most of the patients report they experienced cervicalgia with pain radiating to the shoulder blade and then down the upper extremity, mostly in the ulnar distribution, and associated with paresthesias. Occasionally, pain and paresthesias may radiate in the median nerve distribution or on the whole end. There is quite a significant group of patients that will present pain radiating on the axilla and the lateral thoracic wall. In some cases, and they are mainly male patients, pain may also radiate in the pectoral area. And it's quite interesting that some of these patients were initially misdiagnosed as cardiac pathology. And then a much smaller group of patients presenting pain on the ipsilateral hemiface and nape with migraines very often. And few patients, they may also present an ulnar sign. which may be on-off and related to the crisis of migraine as well. Typically, pain and paresthesias worsen during the nocturnal rest and may be triggered or worsened when the patient carries weights and when they perform repetitive movements, especially when they have to work with prolonged shoulder abduction. If you open a textbook, you are going to see that it's a very important part of the neurological examination to include provocative tests. And there is a long list of provocative tests, but those that in my experience have become particularly helpful are the three that you see at the bottom of the list. Bruce test, which I always perform at the same time I examine the patient, is probably the one that I consider the less important. Then a more significant percentage of patients present a positive traction test, which you have to do asking the patient to carry a heavy bag and see if that triggers the symptoms. But definitely, in my opinion, the one that is the most significant one and present almost in all patients with TOS is the supraclavicular tinel sign. Occasionally, there might be also an infraclavicular positive tinel sign. I assess my patient with an MRI of the cervical spine, of the brachial plexus, and electrodiagnostic tests. The MRI of the cervical spine, most of the time, is absolutely unremarkable, except for a straightening of the cervical column. Electrodiagnostic tests are systematically unremarkable, but it's important that these patients are studied with EMG and nerve conduction study, because the superimposition of other entrapment neuropathies is quite a likely possibility. So some patients may also present a carpal tunnel or a cubital tunnel syndrome as well. But the core of the assessment, at least in my opinion, is a dynamic study of the MRI of the brachial plexus. What we try to do is that we try to understand exactly what happens during shoulder abduction. And we study the patient focusing on the scalene triangle, the costoclavicular space, and the retropectoralis space, both in neutral position and in shoulder abduction. And then what we do is that we compare these measurements, and what we see is that if the symptomatic side has a narrowing of the space which is above 50%, it can be considered confirming the clinical diagnosis. Now, it's very interesting to see that in my experience, I have found there is a very strict correlation between the positivity of the TOS triad of the provocative test I mentioned before, and the dynamic MRI study of the brachial plexus. And this is very clearly shown in this slide, where you can see that when I get the three positive tests of Bruce, Tinel, and traction test, the MRI findings seem to be always supportive of the clinical diagnosis, whereas it's the way around when there is no positivity of these provocative tests. There might be cases where we do not have insufficient evidence on the MRI, and this is related to the presence of false negatives, which can be explained considering that this is a long investigation and therefore we may have movement artifacts, and also the fact that we might not actually be able to recreate the same conditions that we have in real life, because of course the study is not done with gravity. However, we have to say, as I said, it's a very significant tool. And to go back to my series, out of those 46 neurogenic DOS, 21 cases were given an indication for surgery, and 15 of them eventually accepted to be surgically treated. All the surgical cases had an radiological confirmation except 2, in which I eventually decided to go for surgery anyway, because the clinical presentation based on the clinical history and the neurological examination was definitely very supportive. And on surgery, I found evidence of vascular anomalies that would configure a neurovascular conflict. Concerning surgeries, all the patients are always operated with an anterior supraclavicular approach. I always do the procedure under magnified vision and with the presence of a nerve stimulator. The incision is above the clavicle in the suprascavicular space. And one of the things that I regularly encounter are very bulky veins. Now, Christian has already given a very comprehensive overview of the surgical approach to the brachial plexus, and I will just focus on a few concepts. I think it's extremely important in the surgery to identify the omoioid muscle, because you have to aim to perform the scalenectomy in the area below delimited by the omoioid muscle. The transverse cervical vessels are usually considered like a landmark because they run in front of the upper trunk. But I can tell you that in many of these cases, I have seen that they were not there, but running in between the anterior, the upper and the middle trunk. And as I said, probably responsible of the neurovascular conflict. On the left side, you should always pay attention to the lymphatic duct, because especially in patients with an high body mass index, there might be also a net of lymphatic network, lymphatic vessels in the fat tissue and the cervical fascia. Christian already mentioned how important is to identify the phrenic nerve, and this is an essential step to identify the phrenic nerve before you start the scalenectomy. So once you have identified your phrenic nerve, you also have to consider that you have to rule out that there is not a double phrenic nerve, which is something present in 10% of patients. And then you can start the scalenectomy that aims to give you a complete decompression of the neurovascular structures which are finalized to obtain this kind of view. You need to expose well the subclavian artery and all the trunks, especially the lower trunk. You also have to perform a neurolysis of the adhesions that might be present between the structures, because the fact that there was a compression resulted in all these elements to be clustered together. And pay attention when you perform this neurolysis, because the dissection may be also on fibrous bands between the lower trunk, the Simpson fascia, and therefore with the possibility of damaging the pleura. Occasionally, as I said, you might encounter accessory arteries and veins, and it's important to ligate them in order to have no conflict with the neural structures. There are also some other surgical maneuvers which might be considered optional. The resection of the pectoralis minor tendon is something that I do quite often, especially in male patients, and it's done via an incision along the deltoid pectoral groove. The resection of the cervical rib is something which, in my experience, is actually not regularly needed. Very few cases. Concerning post-surgical complications, there is a long list of complications in the literature. Sorry, but I think the one that is more statistically likely to occur is probably the lymphatic leakage. Concerning the outcome, I have to say, in my experience, I haven't observed the postoperative complications, and patients usually experience a progressive subsiding of pain and paresthesias. It's interesting to note that those cases that presented an Horner sign immediately had a resolution of the Horner sign after the surgery. In conclusion, TOS without neurological deficit can be diagnosed if you consider the high value of the TOS triad of positive provocative tests. I think among this triad, the most important sign is the supraclavicular TNL, and the association of a positive TOS triad with a dynamic study of the brachial plexus on MRI can represent a very good diagnostic workup to confirm the diagnosis in these cases. Before I conclude, I would like to remind you that we just launched WFNS Peripheral Nerve Surgery Committee on social media, and you are very welcome to follow us on Facebook and on LinkedIn. I'd like to thank you for your attention and say a big thank you again to the WFNS Education and Training Committee. Thank you so much.
Thank you, Debora, for this excellent presentation. Like usual, very important controversial issue. We are now in due of time continue with our next speaker, Dr. Amit Thapa, with brachial plexus injuries presentation. And feel free to put your questions in a question and answer chat box, and we will answer you in the moment of discussion. So Amit, please continue.
Thank you, Lukas. Well, is my screen visible?
Yeah, it's visible, yeah.
Yeah, thank you once again. And good evening from Nepal. And I am supposed to talk on management of brachial plexus injuries, a very good topic. And thank you, WFNS Education and Training Section, as well as my team at Peripheral Nerve Section, WFNS Committee. I have nothing commercial related to this presentation as a disclosure, even though some terms may be used, but that is only for purely educational and sharing experiences. And the photos I share are basically from the consent from the patient, and just to illustrate how the effects of these surgeries do lead to the patients with. Well, brachial plexus injuries, as we all know, has a high medical, social, and health economic relevance. And once you give them their life back, when they're functionally reactive, the smile on their face is really enlightening. And this is how someone feels when he has lost his right hand and now he's able to write his name on a paper with his own pen. It gives them an immense sense of satisfaction. So what I feel that all the effort, all the challenges we do take up while we are managing these patients actually gives a lot of satisfaction at the end of the day when we have a good results. Sadly, brachial plexus injury repair is getting neglected because most of the surgeons, particularly neurosurgeons, feel that this is a very rare problem and too complicated to deal with. And the results are very unsatisfactory, particularly the initial ones. And the long duration of the surgery does not allow these surgeries to be done in our busy centers where the OR time is very limited. However, what I find from my experiences, as well as from the colleagues who had been a trailblazer in the world managing these patients, we find that these are basically a myth and apprehensions. And the newer advances and the systematic approaches have very improved outcomes. Well, the presentation of mine would not be able to completely cover all the aspects of brachial plexus injury repair, but I will definitely like to cover the basics and the most general aspects of this particular problem. Now, when we talk of the population data, in 1990s, there were many publications from North American population, which has found that the prevalence of the adult brachial plexus injury happens to be in 1.68 to 2.8%. And in polytrauma patients, nerve injuries can go as high as 2 to 4%. However, the hospital data are grossly inadequate, and that's why these population-based data need to be understood. Now, what is much more challenging is that most often these patients are young, healthy adults, which are ranging from 14 to 63 years old, and that's why this becomes a very important in the national role also. Well, children are also victims of brachial plexus injury. However, the most common injuries these sets of age group of patients have is an obstructive brachial plexus palsy, which can occur in 0.5 to as high as 4.6% per 1,000 live births. And the risk increases in newborns with increase in the gained birth weight, birth deliveries related issues like vacuum assisted, or in diabetic women whose baby's weight is more than 4.5 kgs. Well, brachial plexus injury is just not a simple nerve injuries, and this is because there are a lot of intricacies how the nerve travels from its origin at the root, and then as it comes out of the axilla, and then it goes up to the limbs. Henceforth, it's all about the mechanism of injury which actually has brought up this particular problem to the patient. It can be a fall with an outstretched hands or fall on the shoulder, even when the baby is coming out of the mother's womb. And because of which the mechanism of injury has been defined, has been classified as either high energy or a low energy or a complicated ones, which can be because of electrical, thermal, radial, or chemical injuries. And subsequently, the injuries it produces are of a varied type. Now, Lifford classification, which has been modified by Powers, actually has classified these types of etiology into 4 different types. Type 1 are the open injuries, either because of stabbing or low velocity gunshot or high velocity gunshot or blast injuries. Type 2s are closed, which can be at the level of different C5, C6 or C8T1 or C5T1, that is global, or panplexus injuries. Pathological and nitrogenic injuries can be iatrogenic or can be post-radiations or malignancy. And then type 4s are obstetric palsy. Now, what the most important concept which we all need to understand is the preganglionic and the postganglionic injury, which has been defined whether the injury occurs proximal to the dorsal root ganglion. Because if that occurs, these types of preganglionic injury actually is an avulsion of the nerve root, which usually occurs from hide injuries. And in these cases, there are no proximal stump. So there is no neuroma formation. That's why TNDLS is completely negative in these patients. And on MRI, one may find pseudomeningeal, and then clinically there will be denervation of the neck muscles. And then in the lower, if in case lower plexus like C8 and T1 roots are involved, and the patient may present with Horner signs with ptosis, meiosis, and anhidrosis. And a common test, clinical test, which is histamine test, which has been shown to be very sensitive for C5, C6 level, has been shown to be positive in generating a neurogenic response. That is the third phase of the triple sequential responses. However, the postganglionic injuries are those cases where the roots remain intact, and they're usually from tractions, and the pseudomeningeals do not form in these patients. Now, how this is different is that the preganglionic injuries, the chances of spontaneous recovery is almost nil. And for these patients need to be taken up for the surgery as soon as possible whenever the diagnosis is made, unlike in the postganglionic where one can wait for the self-recovery in other types of injuries. Now, very good classification which has actually illustrated how histologically the nerve is affected was brought up by Seddon in 1943, how he defined it as neuropraxia, exonortmesis, and neurotmesis, where neuropraxia, as we all know, is a transient block, is a physiological block where there is no anatomical damage to the nerve itself. However, in an exonortmesis, there's a lesion. However, the nerve is in continuity, so henceforth, the perineurium and the epineurium are intact, and henceforth, exonortmesis do have some chances of recovery, but neurotmesis, where the nerve is completely divided, where the endoneurium and perineurium epineurium is also gone, in these cases, the spontaneous recovery chances are almost there. So this was again defined by Sutherland into grade 1, 2, 3, 4, and 5. And subsequently, these define how we manage the cases. Now, the most complicated case of brachial plexus is the presentation. The presentations varies a lot, and henceforth, one must have a very, very high clinical suspicion whenever we are dealing with any patients of this sort, particularly in polytrauma patients, where I just mentioned that 2 to 4% patients can have a brachial plexus injury. So we should go for a thorough clinical examination, evaluating each of the movements in the upper limb, from shoulder to elbow to hands. We should understand that if there is no diagnosis, we are not going to treat these patients, because once the duration of surgical intervention is gone, the optimal time, then the recovery time is also not going to happen. Now, for each cases, what we are doing in our case is we are fulfilling this chart. This is also known as Modi-Diopnik chart, where we fill up the motor and the sensory function evaluation on the chart, and which helps us to identify the pattern of weakness, which also helps us to vocalize the extent of injury. With this, we also want to assess the donor nerves. We also want to assess the active and the passive range of motion. We want to rule out any quad injury, Hoffman Tyndall sign, to see whether regeneration is there or not. Vascular examination, because we need a perfused limb so as to have a neurotized limb. And then a fracture needs to be fixed first, because we need a stable limb so that the mobility can be put in later. And each case gets an EMG and NSAID study followed by MRI, cervical, spine, and brachial plexus. So if in case we have any confusion in these patients, then we like to repeat the clinical examination at 2-week interval. And EMG and CV is first done at between 2 to 3 weeks after injury and followed 3 to 4 weekly intervals. Now, EMG and CV is very helpful because whenever we have any doubt that there's a preganglionic or proximal injury, or there is an exotmesis or neurotmesis, or in other cases like neuropraxia, then this evaluation helps us to define the things. Now, MRI can see the nerves, and henceforth, MRI can also see the lesions, as is seen in the right side of the picture, the presence of a pseudomeningeal, which can actually tells us that this is a preganglionic injury. Now, as I said earlier, depending upon what type of injury the patient has, we can decide as onto the management. So if in case patient has neuropraxia, then we can just wait and watch. As usually most of the patients will recover, that to a complete recovery can happen within 3 months of time. However, exonotmesis can be complete or partial. In the complete exonotmesis, again, the recovery chances are almost nil, and henceforth these patients do not have to wait for longer. But then we need to see if in case there's a mixed injury, then we have to wait for at least 3 months to have any improvement. Now, the problem is that the more we wait, the more we are losing the time for innovation or innovation, because it has been shown that though the initial concept was that we can wait till 12 months time, we have seen that if in case we are waiting even beyond 6 months time, that the muscle is actually losing its potential to regenerate. The motor end plates are denervating, and henceforth, even after having a good renovation, the motor end plates actually forget to fire properly. And this has been actually shown in the rat models, and henceforth, we need to sometime tighter as to what would be a good window for renovation. Now, depending upon the time of injury and the patient when presents to us, we can define what type of management we can do. The most important or the most successful management has been the neural management, that is by using a nerve graft or a nerve transfer or a decompression surgery as soon as possible. But as it goes beyond 12 months to 18 months, then these types of nerve repairs or nerve transfers are not possible. Henceforth, we only can do for a decompression. Then comes the muscle, where in case where there's some initial contractures or there's a limitation of the range of movements, then we can use certain maneuvers. However, tendon transfer or pre-gracilis transfers are reserved for patients who have come back very late. And similarly, the bone maneuvers are actually started whenever there's a palsy after patients following after 1.5 to 2 years. So in a nutshell, there are a lot of things we can do with these patients. Conservative managements are basically reserved for only for patients with neuropraxias. So whenever the patient has exotmesis and neurotmesis, we like to go for a nerve repair. So the first and foremost thing which we do in most of the patients is the neurolysis. Now, neurolysis is of two types, either external or internal neurolysis, which is reserved most often for the patients who are complaining for pain. And we like to see if the patient is having any neuroma, and depending upon the nerve action potential it generates across that neuroma, we can actually decide whether a simple neurolysis will work or not, because the NAP will improve once the neurolysis is effective. However, if in case it is not effective, then we have to cut that neuroma and then do an end-to-end anastomosis. Now that leads to another type of management, that is the nerve repair, that is also known as end-to-end anastomosis. Now, we all know that the nerve can be mobilized by around 5 millimeter. So if in case any nerve which the defect is not more than 5 millimeter, we can do a direct end-to-end anastomosis. However, this has to be considered that the nerve can be stretched to a max of around 8 times, or rather 8%, because the moment we go stretching the nerve more than 16%, then the patients develop an arterial perfusion problem, and this nerve anastomosis actually scars and do not work later. So in the patients where the gap is more, we can actually use an autograft, which is usually used in an autogloss manner. So here the major workhorse for our nerve injury repair is the sural nerve, which we actually can harvest from the lower limb. And then there are other autologous sources like vein and also the vein muscle complex, which has not been shown to be that much beneficial, but if in case the defect is large, then we can use it. However, this graft can work for distances over centimeters, but not beyond 50 to 60 centimeters. And of course, there are certain other grafts like collagen or coprolactone or polycholic acid grafts, and also allografts, so which can So these things can be actually used, and however, these comes with a cost, and they also can help you in regenerations. Now, the other thing which we'll be discussing more on this presentation are the nerve transfers, also known as neuritizations, which can be intraplexal. That is to say that if we are using the nerve grafts from the same plexus, and extraplexal if in case we are using grafts from the opposite side or from the outside that plexus, and supercharge end-to-end site transfers. So diarizotomy is a procedure which is reserved for pain management if in case patient has pain beyond 1 year of trauma, and functional pain, muscle and tendon transfer, and arthrodesis are the talks which will be covered in the future topics presentations. Now, each of these methods, even though they have some indications, they have also limitations. So as I told about the nerve repair, if in case the nerve repair is done immediately, that is within 72 hours, then the contraction following a nerve injury is very less. But after 72 hours, almost the nerve shrinks, the nerve edges shrinks by 28%, and also the nerve ends actually gets blotted out. So that's why you have to cut them off before you attach it together. So that's why the nerve repair, if in case it is done early, it's better. But then if in case it's late, it's not going to be that much beneficial again. Similarly, in the nerve grafting, there's a donor mobility, which is there, and that's why we have to consider the expandability of the donor nerves. Allograft requires a long duration of immunosuppression, and this comes with a cost. Conduits are only useful for a very short length, so example less than 3 centimeters, and they are used for those sensory nerves which are not located in non-critical areas. And similarly, there are other problems. So for the individualized treatment for any clean open injuries, we need to explore and immediately cut to repair it. And in clean incised injury, it's done the same. In contaminated open injuries, we should tag the nerve ends initially and then do a delayed repair as soon as the wound is healed. Depending upon the size of the gap, we can go ahead, as I said earlier, if in case the gap is less than 5 millimeters, then we can go for primary repair. Beyond this, we should go for an autograft and an allograft. So nerve conduit only helps in the shorter length. Now, acute exploration and early explorations, we have already talked about. So whenever we have a mixed type of injury, it's always better to wait so that any post-ganglionic injury, if in case it is associated with conditions like neuropraxia or with an incomplete or a partial axonotmesis, can recover by 3 months. However, if in case we do not see any subsequent recovery on clinical as well as EPS examination or electrophysiological examination, which are conducted every 3 to 4 weeks, then we should not wait. And we should go for surgery as soon as possible. And then in any other cases, we should not wait beyond 3 months. Now, Christian has actually in his presentation done a very good job by showing the various anatomical things. So whenever we are trying to repair or do any intervention at root and the trunk level, then the supraclavicular approach is the one. If in case we are opening the cords and the branches, then the infraclavicular approaches, and then in combined approaches, we go for the complete exposure. So the goal of intervention is fully functional hand, but we should understand this is not practically possible. So what we are trying to do is, first of all, establish the etiological, anatomical, morphological, functional, electrophysiological diagnosis. It is just like going on a war. We need to know the enemy to its completeness. And then we have to assess the extent of the damage. And then aim is to provide the elbow flexion extension, to stabilize the shoulder, and to provide abduction and external rotation, because that helps the patient in his day-to-day activities. Scapular stabilization will help him to raise his arm beyond his shoulder, and then essentially function over the dorsum of the hand and to decrease pain to the maximum, and hand function if in case it is possible. However, it is very difficult because the regeneration starts from the spine itself, and henceforth it takes a very long time. And for the close traction injury, the philosophy used is almost similar as we have already discussed. So say, for example, if the patient is having a C5-6 injury, if in case it happens to be a preganglionic injury, like the case which you're talking about here, he had an axillary nerve injury, and we had done a neuratization of the nerve using spinal accessory, and we could see a very good recovery. So this was an isolated injury of an axillary nerve involvement more. However, if in case it's a C5-6, then we can go for a suprascapular and to spinal accessory nerve anastomosis for shoulder abduction, external rotation, and we can go for a double overleans for the neuratization of the musculocutaneous nerve, so as to able the patient for elbow flexion. And Somsack procedure can be used for allowing the patient for shoulder abductions. However, if in case it's a post-ganglionic injury, at that to an early phase, then we can go for a C5 lateral cord or upper trunk and neurotization, or C6 to posterior cord neurotization procedures. Similarly, these are the different other reports or the case reports where we have found very good results of these types of maneuver. So we can see certain movements even at the 4.5 months duration, and this is the patient after 9 months. You can see the patient can lift up weights, and also this patient is after 5 months, where you can see almost a near normal recovery happening at his shoulder and at his elbow flexion. We have over the time modified our approaches. So rather than going supraclavicularly, we are now going from a direct approach. So this is an approach for spinal accessory to axillary nerve neurotization. So spinal accessory nerve is used to neurotize the suprascapular nerve, which has been shown on the left side of the screen, and on the right side is the axillary nerve neurotization using the triceps branch. So this is how we do it after exposing these areas. Now for the C5, C6, 7 injuries, so we go again in similar manner. Only thing is that we do not have the luxury of using the triceps branch. In those cases, we use the intercostal nerve to neuritize the axillary nerve. And for the elbow extension, we can use the medial pectoral or intercostal median nerve to neuritize the long head of the triceps or the nerve anastomosis. However, if in case it's a post-ganglionic injury, then in addition to the C5 and C6 nerve root, which is available to us, we can use a C7 nerve root to neuritize the medial trunk and the posterior cord. And this is how it happens. So the patient has a very good recovery after a period of 12 months. And this is an improvement which is seen after 9 months. And this is another patient with improvement after 9 months. So this is another patient who had a very good recovery after, I think this is after 6 months of the repair. Now, the special case may be a C81 injury where the patient is young and operated early. Then we can use an ipsilateral or contralateral C7 to lower trunk to medial nerve to medial cord neurotization procedure. And if in case the patient comes late, then we can go for a brachial nerve to median and ulnar nerve, as well as nerve to brachial and supinator to posterior nerve. So this is a case of a complete or a total C5T1 injury. So we have done a lot of neurotization from contralateral C7 to intercostal. So in these cases, this is all an extra plexural repair because there is nothing inside the plexus which can give you a good donor. So in those cases, we can use a combination of a contralateral C7 to multiple intercostals to neurotize to achieve the elbow flexion, elbow extension, and of course, shoulder reanimation. So this is how we open up the intercostal nerve and then try to neurotize it. This is suprascapular neurotization. Now, someone may say that, okay, we see these pictures, patients are moving the limbs, but then this is just a cosmetic benefit. However, there have been a lot of studies on this. This was a publication in 2017 where they have found that the overlying nerve transfer and similar procedures are highly cost-effective strategies for storing elbow flexion function and improving the QOL. Henceforth, the data is there that it gives help. The thing which has been upcoming in the last 2 decades has been a supercharged end-to-side transfer. Now, what we have been doing till date had been an end-to-end transfer, which is a direct anastomosis. But the supercharged nerve transfers are these days used for as a booster surgeries. Whenever we do not see a very good benefit or an optimal outcome of the patients, then we can use a donor nerve fascicle and then try to innovate the already recipient nerve and just produce a small crush distal to the anastomosis so that that particular crush injury can incite the nerve growth into it. So this is how the sets work, and it has been shown to be very useful. A word about DRES or dresotomy, and this is a procedure which is done for pain, basically in those patients who have a preganglionic injury, as seen on the photograph in the screen. So you can see there's an absence of the rootlet before the lesion. And then after the lesion, you can see there is a depth or a mark which has been created in the DRES area. So this procedure has been shown to be very beneficial. And this has been now been delivered in various manners. So what we are doing is a microsurgical and radiofrequency lesioning. There are reports where the people have used lasers as well as ultrasound based ablation technologies also. Now, this being a very long time taking surgery, it needs a lot of ergonomics. Otherwise, after going for a surgery for this duration, one may get tired and cannot do it. So just to share experiences of more than around 250 patients with us, most of the patients approached with us had been a patient of neurootmesis followed by axonotmesis, and we found that the the outcome actually depends upon the severity and the location of the injury, the timing of the surgery, age and overall health of the patients, and the experience and the skill of the surgeons, as in any other literature which has been published. So in overall, we have for 50 to 95% improvement, and the good recovery rate had been 76% as when we combine all the patients. And none of the patients have died in our series, and there have been 2 cases with minor wound infections. And this is a very important slide which I like to show to all my colleagues. The delay of surgical intervention actually affects the outcome. Henceforth, it is very important to act on timely in these patients. Beside the brachial plexus injury, we also have a lot of peripheral nerve injuries, and these are the patients with the radial nerve, median nerve, and all sort of peripheral nerve injuries, which has got benefited out of this. This was a case where we, the plastic surgeons, orthopedicians, have worked together. This is a patient of a crush injury, which is a completely limp, or rather a chopped off arm, and the patient is now able to feel his arm and is able to move it. This is almost after a year of intervention. So just sharing with you small pearls to improve results. Early diagnosis and proper work is very important. Time is the key. One have to remember, pre-chronic, we do not wait more than 3 weeks. This is just to give some time for the neuroplexic injury to improve. Post-ganglionic injury, if in case it has to recover, it will recover within 3 months. After that, we have to intervene. So the best to intervene in the adults within 12 months of the time, and in infants 18 months of the time can be allowed. However, aim of this surgery should be well defined and should be well discussed. Patients should not be over expected or of the expectant of the outcomes sometimes, which do happens. And the stage surgery, whenever we are planning, we should intervene rather than wait. So best outcome with the surgical repair is achieved by dedicated nerve repair. We focus exposure, good donors, and distal anastomosis, using electrophysiological techniques at each level, tensionless anastomosis. So there should be a sort of redundancy at the level of anastomotic line. Direct cooptation is very, very important, and we try to avoid graft as much as possible by mobilizing the nerve. However, mobilizing the nerve too much is also detrimental, so that's why we have to be careful about the gap. And the transfer surgery as early as possible. In the stage surgery, we already discussed. So microsurgery technique, we also know that it has to be an epidural stitch. Interfascicular stitches are also being applied, but then it can cause a lot of scarring. So epidural is the one we try to do it as much as possible. And then, so we try to do a glue anastomosis like this. Is a dip and drip technique by which the glue is posed. However, in countries, low middle income countries like ours, glues are not very readily available. So we are trying to going to for the microanastomosis as much as possible. And the best outcome is also achieved by selecting good donors. So, and the two which have a similar neuromuscular units, and re-innovate the recipient graft as close to the target muscles or as close to the end plate as much as possible. And whenever using a graft, the short nerve graft less than 10 centimeters better. If in case the gap is more than 10 centimeters, you should always be using a vascularized nerve graft, and the graft should be almost 20% more. Other than that is the supervised physiotherapy. So one should always go for a supervised physiotherapy whenever being allowed to, because patients actually get demotivated if they do not get any outcome within 3 to 6 months. And so these patients needs to be counseled at the timely and always have to have a supervised physiotherapy. And this is what we are following here. And beside that, we should always be very much vigilant about the signs of recovery. So if in case the recovery is not occurring within 6 months, even not being seen on EMG or NCD study after intervention, we should plan a second stage of salvage surgery if in case it is the response is not acceptable. The most important thing which I have found after starting the practice in my country had been to create a social awareness. There is a innate sort of belief in the community that these types of surgeries do not help, and henceforth we need to have to spread the awareness about these type of reconstructive neurosurgery, and also to standardizing the indications and the facilities. And the most important is to gather the evidences from research which is ongoing in the country. So to conclude, we should always have a high clinical suspicion, and examination should be the most important task of any clinics which is managing the brachial plexus injury. So current trend is early repair and always as distal as preferred. Some treatment should be offered, and these patients, if in case they have a primary failure, should be re-explored. And the benefit of the brachial plexus repair, which we have found, as in any other literature in the world, depends upon the factors like the type of injury, timing of intervention, surgical techniques, and post-operative follow-up. And whatever good outcome in our patients we have seen has happened in those patients who have came early and who have continued in follow-up. So dedicated follow-up is very, very important. So we counsel the patient that this is just not a one-time investment. They have to be continuing the follow-up, because we know that the cortical training is very, very important in these patients to achieve. And then standardized protocols and the newer tested options, they do provide better alternative. And of course, the lack of awareness and the socioeconomic reasons are something which we need to fight for, so as to allow our patients to have an early intervention as soon as possible. I would definitely like to acknowledge the mentors and the seniors in this field who have actually done a lot of good things, and I'm blessed to have interacted with them and my team who had been working behind the scenes, working for my patients and giving the best to the patients. I'd like to acknowledge the World Federation of Neurological Societies for giving us this opportunity, and thank you all for the patience listening. I'm available for any queries. And before I depart, I would like to invite you all for the 11th National Conference of Nepalese Society of Neurosurgeons, which is happening in the eastern part of Nepal this time from 14th to 16th November 2024. Thank you.
Thank you, Amit. Excellent presentation. Very informative and very important for the raising awareness about the importance of treatment brachial plexus injuries. Debora, please continue with this moderation now, and Mehmet, what is the plan after this?
Yeah, we should start our next symposia in 10 minutes. So then we must finish our discussion in 10 minutes.
So maybe if there is any question from the people online, we may briefly start a little bit of discussion. Otherwise, if there is no other question, maybe we can just conclude. And do we have any questions? I don't see any question. Do you see any?
In fact, my question is that in case of root avulsions together with brachial plexus injury, what's your policy? Actually, let's say there are both root avulsion and plexus injury.
Well, thank you, Mehmet, for a very, very good question. In fact, this was the same thing I spoke in the talk. These injuries are complex and they always present in combinations. So it's very, very less that we see very isolated root injuries. More often, these comes with combinations. And in these cases, we definitely want to see these patients over weeks, not months even, and over weeks to see whether there is some improvement. Because if in case this is just a neuropraxia, then some element of neuropraxia would improve. And the extent of injury which we evaluate at the first evaluation, we would see the patients improving. So in those cases, our intervention would be much more focused. And secondly, if in case it's a root avulsion, those areas, they are not going to improve at all. So we can actually define those areas where the root avulsions are there and go for a direct intervention. So my philosophy would be to wait for the neuropraxic element and the partial axonotmetic element of the plexus injury to improve. However, if in case there's a root avulsion, then we do not want to wait for more than 3 weeks. Debora, you would like to add something to this?
Well, something that I would like to emphasize is that we definitely need to try to get to the diagnosis of the type of damage sustained by the brachial plexus as soon as possible, because the detection of avulsions definitely changes the timing for surgical indication. We know that if we have avulsions, we cannot expect any spontaneous recovery. Therefore, compatible with the general condition of the patients, we have to try to go for surgery as soon as possible. What I may say is that what Mehmet just mentioned actually highlights the importance of brachial plexus exploration. There is a trend which I have to say it has been brought forward mainly by the American surgeons about not exploring the brachial plexus and just proceeding to nerve transfers. And I believe this is actually quite a significant mistake. And especially we have to consider that there is evidence that in 5% of brachial plexus injuries, there might be a double injury. You may have a supraclavicular injury, but you may have a rupture, mostly affecting the musculocutaneous nerve or the axillary nerve and the infraclavicular nerve. So if you think that you have avulsions, but you do not check that you might have also a distal injury, you may end up doing a reconstruction which eventually is doomed to fail simply because there is another injury along the course of the nerve. So this is very important to keep in mind. So Mehmet, thanks so much, because you have actually raised a very important point when we perform brachial plexus exploration.
Thanks a lot. It was a great symposia, really. I enjoyed all the talks. Thanks a lot for great contributions. Probably Abuzer may say something. Abuzer, you unmute yourself.
As a young neurosurgeons, we learned a lot from this issue. As everybody know, these issues is very challenging, not for all young neurosurgeons, also all neurosurgeons. Thanks for your contributions.
I think the neurosurgeons in general, they are scared of the anatomy of the plexus, especially. What do you think, Debora?
Yes, there is something that I would like to mention. Young neurosurgeons should try to appreciate the incredible challenges that peripheral nerve surgery offers to them for many reasons. First of all, because it's an intellectual challenge, because even if we have electrodiagnostic tests, even if we have MRI, or for instance, in cases of peripheral nerve injuries, we also have ultrasound, as Christian certainly would emphasize. We still have to rely mainly on clinical examination. That's the mainstay of our assessment to understand what is the damage sustained by the nerve or the brachial plexus in this case. So it's a fascinating intellectual challenge, but the young neurosurgeon should also consider that peripheral nerve surgery is essential because, first of all, it enters in the differential diagnosis. Many of you probably do spine surgery, and I think that you should focus on the fact that sometimes cases of failed back surgery might be related to the fact that there was a peripheral nerve issue which has not been recognized. I can tell you the number of patients I have with a TOS that were offered surgery for ACDF is maybe just because there was a little bulging disc, not consistent with the symptoms, but the neurosurgeon couldn't see any other issue consistent with the symptoms of the patient. And then, besides the fact that it's a very useful tool in your hands, we have to consider that it is microsurgery. So start to train on peripheral nerve surgery means that you are going to gain excellent microsurgical skills that can become extremely useful also if you want to dedicate to other subspecialties of neurosurgery. Now, I think there has been a question that I saw in the chat about when to do electrodiagnostic studies in these patients, and I'd like to remind that EMG and nerve conduction study in cases of injuries should never be done before at least 3-4 weeks after the causative mechanism, because before 3 weeks, EMG and nerve conduction study cannot differentiate between neuroapraxia and the more severe grades of injury.
Okay. Thank you. Thank you a lot. Thank you, Debora, Lukas. Amit Thapa, Christian, all the speakers.
It was our pleasure. I do hope that we are going to have further chances of collaborating with the Education and Training Committee. And concerning the young neurosurgeons, I think we are all very eager to try to strengthen the collaboration with the young neurosurgeons group as well, and recruit as many young people into peripheral nerve surgery as possible. Thank you so much. I'd like to thank my colleagues. And I think it's time that we just leave and give space to the next webinar. Thank you so much.
Okay, thank you. Thank you. Goodbye.
I think we can start the next webinar, Professor.
There is 1 minute.
Yeah, yes.
Yeah, I think
Campero or is here, Matías is here.
Dr. Campero is with us. Matías
yes,
is with
yes,
us.
yes.
Hello.
And Ma.
Hi, welcome. Alvaro, one person is lacking, Dr. John Lee.
Okay.
Do you have his phone number? Is Dr. John Lee with us?
No, I don't.
Only he is lacking.
I don't have his contact.
Okay. Dr. Matías is with us. Mauro Segura is with us. Jose Osvaldo Oliveira, is he with us? I couldn't see him.
No, I don't see that.
No, he's not with us. Sorry. I guess he will join. Do you have his number, Jose Osvaldo de Oliveira?
Yes, I will send a
Yeah,
message now.
please. Please. I think we can start. Dr. Alvaro Campero is the moderator. This is the management of trigeminal neuralgia, a difficult topic. Yes, it is time for starting, Dr. Alvaro.
Okay, thank you.
Remember, John is joining shortly.
Sorry?
Mehmet,
Yes.
John is joining shortly.
Who is joining?
Okay, we will see when he joins.
Okay, let's go to start. Okay, hello everyone. Thank you for being here. We will start the Zoom about the trigeminal neuralgia with 4 topics: anatomy of the trigeminal nerve, then the surgery with the microscope, then the surgery with the endoscope, and finally the percutaneous treatment of trigeminal neuralgia. So the first speaker is Dr. Matías Baldoncini from Argentina. So please, Matías, go ahead.
Good morning to everybody. Good morning. It's a pleasure to see so many friends from around the world. And thanks again for the invitation to the WFNS. It's a huge pleasure for me to speak about trigeminal neuralgia, especially being there Professor Álvaro Campero, because I learned every single detail what I know about trigeminal nerve surgery from him, and that's why it's a huge pleasure to me. We will try to observe the different details of the anatomy of the trigeminal nerve, especially focus in the topic that we are trying to emphasize nowadays. That is the treatment for trigeminal neuralgia. And we know that not only for trigeminal neuralgia it's important to learn the anatomy of the trigeminal nerve. As we can see, the anatomy of the trigeminal nerve is very important, and it's a really complex anatomical structure, because it goes from the posterior fossa to the middle fossa, and one of the branches enters to the orbit, and the anatomy is really complex. And as everybody knows, the trigeminal nerve is a nerve who provides the sensibility, the sense of touch and pain of our face. And it's divided in the 3 branches: B1 or ophthalmic branch, B2 or maxillary branch, and the B3 mandibulary branch, or the inferior branch, where the inferior branch, it's in near contact with the motor root of the trigeminal nerve, very important for the movement of the masseterian muscle. The trigeminal nerve is an important nerve that the origin of this nerve is located in the anterolateral surface of the pons. And it's a very important landmark, because from medial to the origin of the, or the entry root, or entry zone of the roots of the trigeminal nerve, from medially, we will find the pons, and laterally the middle cerebellar peduncle. That's why it's a very important landmark. But it's an important nerve. With the second nerve, or ophthalmic nerves, there are the more important nerves in order to the quantity of fibers that runs inside of the nerve. And it's a very important anatomical landmark, not only for the separation between the pons and the middle cerebellar peduncle, because there are an important safe entry zone to the pons. That's the name of this zone is the peritrigeminal nerve, because the nerves course through the fibers, through the transversal fibers of the pons, in order to reach the nucleus of the trigeminal nerve. That is a long, sensitive nucleus that is located inside of the not only the pons, the mesencephalon, the mesencephalon, and the medulla too. And if we observe this sagittal section of the posterior fossa, and we try to select an axial section crossing in the superior third of the pons, where the nerve is located, we can observe this interesting anatomy of the nerve. This is an axial section of a human head, and we can observe the following anatomical details. The nerve cross from posterior to anteriorly, from medially to laterally, and depending on each patient, but mainly time it goes from inferiorly to superiorly, in order to reach the Gasserian ganglion located in the Meckel's caves, in the Meckel cave, where it's located in the middle fossa. Okay, and the nerve in the posterior, the trigeminal nerve in the posterior fossa can be separated in 3 segments. the segment where it's located close to the pons, where it's the entry zone of the trigeminal nerve. And this point is very important for the topic of today, because mainly times the trigeminal neuralgia caused by neurovascular compression is related to the artery compression in this anatomical point. That's why it's very important to reach this zone if we use the microscope or the endoscope in order to observe if the nerve is compressed or displaced by the some artery or vein at this point. The second part is the cisternal segment of the nerve, and the third part is the part that is entering to the Meckel's cave that we can observe there, like a foramen of the dura mater, where the nerve enters and ends at the Gasserian ganglion. That's very important. In this anatomical specimen, we can observe another important anatomical landmark, that is the suprameatal tubercle, okay? This anatomical structure sometimes it's located in the middle of our approach if we select to operate this nerve using an endoscopic or microscopic approach. So, mainly time we select the retrosigmoid approach, and in some cases we can observe a huge suprameatal tubercle, and it's difficult to reach, especially the distal portion of the nerve. That's why especially young neurosurgeons that start operating this kind of pathologies need to keep in mind that if we are not able to reach this part of the nerve, sometimes it's important to remove the suprameatal tubercle. And of course, the neurovascular complex that's in close relation with the trigeminal nerve is the superior neurovascular complex. Sometimes the nerve it's in close contact with the superior cerebellar artery in the superior surface, and in an inferior surface can be reached by the anterior inferior cerebellar artery or the AICA, okay? And sometimes, like in this specimen, when we can observe a dolichoectasic basilar artery or vertebral artery, can be in close contact with the trigeminal nerve and could be related with trigeminal neuralgia, okay? And not so frequently, the nerve can be compressed by veins, and this could be the reason why our patients suffer trigeminal neuralgia in neurovascular in the neurovascular complex of the superior complex of the posterior fossa. This is a superior view of an skull base, where we can observe here in the apex of the petrous bone, where the cavum of Meckel is located. Okay, and in the cavum of Meckel, of course, we will observe the Gasserian ganglion, and in the Gasserian ganglion, the nerve separates in the three distal branches of the nerve: the ophthalmic branch that enters in the middle part of the superior orbital fissure, the maxillar branch where enters in the foramen rotundum, and in the foramen ovale, we will observe the inferior or maxillar branch of the nerve. Of course, in order to dissect this part of the nerve that is located in the middle fossa, it's mandatory to perform a middle fossa peeling, okay? If we need to operate, for example, the topic of this webinar is neurovascular decompression, but sometimes the nerve can be in close relation with trigeminal schwannomas, for example, and sometimes we need to perform a middle fossa peeling in order to expose the B2 and B3 branches, as we can observe in this specimen dissection. And this is the B1. B1 going through to the superior orbital fissure, B2 foramen rotundum, and B3 to the foramen ovale in close relation with the with the intracranial course of the middle meningeal artery, what is an important element we need to coagulate if we are approaching the nerve in this part of the Gazerian ganglion or the B1, B2, or B3 branches, okay? As I said some minutes ago, in the posterior fossa is very interesting because we have the rule of three. The brainstem have three segments. The cerebellum will have three surfaces, tentorial, suboccipital, and petrosal, and we have three neurovascular relationship or complex, and the trigeminal nerve is in close contact with the superior neurovascular complex, okay? And mainly times the nerve, when we have to operate the patient with classical trigeminal neuralgia, caused by the vascular compression, mainly time the problem is because the nerve occurs very close to the superior cerebellar artery that is here. But sometimes, as I told you, sometimes it can be in close contact with the inferior cerebellar artery, and in less frequently with the vertebral or basilar dolichothoracic artery, or some venous that drains frequently to the superior petrosal sinus can cause in close contact with the nerve and can produce trigeminal neuralgia as well. As we can observe in this vision of the posterior, this is a posterior view of the anterior part of the posterior fossa. This is the sixth cranial nerve entering to the Dorellos canal, and this is the nerve, trigeminal nerve, entering to the dura mater in order to reach the trigeminal, the Gazerian ganglion. That's here we can observe the 7 and 8 cranial nerve and the contact of these duplicated superior cerebellar arteries to the nerve. And here we can observe this beautiful anatomical specimen that represents the real situation that we observe in our surgeries when we need to decompress the nerve to superior cerebellar arteries displacing downwards the trigeminal nerve. That's really frequent. And we don't need to forget sometimes that this vein of the these petrosal veins or vein of Dandy, sometimes we need to dissect this vein in order to reach the trigeminal nerve, or sometimes this vein, the medial location of the vein, these postmeatal veins, can be in close contact with the trigeminal nerve. Something that is really important, especially for young neurosurgeon who operates trigeminal nerve neurovascular decompression or trigeminal nerve schwannomas or tumors located in the cerebellopontine angle, is to preserve as many as we can this vein in order to prevent the venous infarct of the brainstem or the cerebellum. Here we can observe a beautiful endoscopical image trying to observe this suprameatal tuberculum, this very huge suprameatal tuberculum that if I use only the microscopic view, it's very difficult to observe the point where the nerve enters to the dura mater and to the cavum of Meckel. Here, this small branch of the nerve is the motor root of the nerve. And as I told you, the veins need to be preserved because sometimes these veins drains the venous drainage of the brainstem, especially to the pons or the mesencephalon. Here we can observe how the nerves is all covered by arachnoid. Sometimes when we operate the patient that are suffering trigeminal neuralgia, we can observe a very dense, a very strong arachnoid surrounding the trigeminal nerve in our surgeries. Of course, and this will be an interesting topic the next lectures, of course, from Mauro and the colleagues. The position that we use to operate this patient could be in semi-sitting position or retrosigmoid approach using a park bench or only a regular dorsolateral position of our patients. We prefer to use for this kind of surgery to approaching the trigeminal nerve in the posterior fossa, the semi-sitting position, because we feel a little bit comfortable during these surgeries. Of course, sometimes takes more time, sometimes take less time, but at least we need 15 or 40 minutes in order to position our patient in semi-sitting position for an appropriate semi-sitting position of our patient for retrosigmoid approach. That's very important if we use semi-sitting position to elevate the legs up in an upper level to the heart of our patients. We try to not produce venous compress in the neck, venous compression of the neck, sorry, and our position is ready for perform our retrosigmoid approach. We select to mark with this element the asterion, that is an important landmark, and we start our approach to the retrosigmoid approach. And our philosophy, that we try to promote, to share with our colleagues, especially for young neurosurgeons or young residents, and we agree with Professor Abuser Gungor with his philosophy too, trying to go from the laboratory to the operative room, because the anatomy that we can learn in the laboratory, for example, in this double compression of the trigeminal nerve, we can be able to reproduce it in our patients if we train in the laboratory first from the laboratory and then to the operating room, trying to give the best for our patients. Again, thank you very much to everyone, especially for the committee of the WFNS for the invitation. And in this photo, we can observe one of my academical house, that this is the Faculty of Medicine of the University of Buenos Aires, where I live, and everybody are welcome to come here when you visit Argentina. Thanks again for the invitation.
I think I couldn't see Campero. We will continue with the Mauro Segura.
Yes.
You can share your screen.
Yes, I do.
Thanks again, Matías. I think we will have some questions at the end of the session.
Thank you very much. Can you see the screen? Yes, I guess.
Not yet.
Now?
Yes. I think we will see.
Okay.
Yes.
Thank you very much again, and thank you to the organizer for this beautiful webinar. And after the beautiful presentation from Dr. Matías, it's very easy for me to continue with the topic microvascular decompression for trigeminal neuralgia. This is my college, Mario Alexis del Real. We are working in Morelia City, Mexico. I want to do a brief introduction because this is also for young neurosurgeon, because this is a very important topic, and I call this is a strong fight against philosophy and understanding of neurologists, algologists, and other medical specialties. So we have to teach them that is a really area of the neurosurgery. Of course, we all know the previous name was described by Janetta many years ago as dysfunctional syndrome. It's a hyperactive dysfunction cranial nerve syndrome. And after the times pass, we move or we change the name, but it's not only neuralgia. It's not only fascial pain. It's not only trigeminal neuralgia. It's a very complex disease. So this is the problem. One of the problem, the main problem, as Dr. Matías said, the most important and most frequent cause of the trigeminal neuralgia is the vascular compression, as Professor Janetta said, but also there is another factor, as I will describe. In our experience in the last review, we found this number of cases, 486, and most of them were mixed vascular, venous or arterial type. And some of them only venous, 11%, and some of them one artery or two or three arteries, 16. But the most important I want to the young people pay attention is that the MRI is only important to find the tumor cause of trigeminal neuralgia. It's very less frequent, 10% around, but it's very important to find a small or big tumor, a benign tumor like a epidermolysis or malignant or not some aggressive tumor. But that is the point for the MRI. No matter is 1, 3, 9, whatever Tesla, it doesn't. It's not important to do the diagnosis. The diagnosis is only with the clinical data. And of course, we know this picture from Dr. Rotten, but I can say that in the last 22 years working in this small area, there is no a single pattern. There is no easy to find a pattern. It's as much variety as much as patient we have. In general, the most frequent, as you know, it's B2, B3, and that's why the odontologists have a high responsibility to diagnose and to deliver the patient to the neurosurgeon. Okay, so as we can see, this is our experience from this hyperactive dysfunction syndrome from the last 10 years, 1 decade, and I'm going to focus on this primary trigeminal neuralgia or primary hyperactive dysfunction syndrome, and we have to pay attention and also this classification, the classical type, the most frequent as all we know, and the idiopathic type, and other time called the atypical type, but it's about 10% of the old cases. It's also important to recognize that in most of the cases is the same pathophysiology, the same cause, the same etiology. So we found this general data for classical trigeminal neuralgia. Of course, 3 to 1 female to male. The size is not important, but the important point is that up to 8% will become bilateral, not in the same time, but during the long lapse. In some cases, as we know, we have to do the operation at the same time simultaneously. And the average for the age, the patient, is between 47 to 55. Okay, this is general technique, as also present Dr. Matías, but this is not the moment to discuss. We prefer the cubitus position for normal weight, only the head rotation, and for morbid obesity, we use the Parvane or very a complex position, but lying position. Also, the landmark was also Dr. Matías explained, and I'm going to show this video. This is right side, retrosigmoid approach, infraasternal craniectomy. I want to focus, never do it in the asterion. Even the name is asternal approach. We never use the asterion as the first point. And this area corresponds to the sigmoid sinus. This area corresponds to the transverse sinus. This is the angle. And for us, it's very important to show, to discover the roof, the sinus always, in order to take control of this angle and also the other angle in this point before the jugular golf. In average, 2 centimeters diameter is enough to do the surgery, as you can see. And the second tip that we recommend is not open the dura in the curve line, but we open this triangle shape, sorry, and that is enough space to go into the zero-pontine angle. In this point, it's very complicated sometimes to do the coagulation. Also, we need the Mackenzie clips or some treatment for the bleeding from the sinus. And in the next, it looks in the same, but it's different also. Right side, this is the base, the sigmoid sinus. This is transverse sinus. And also, you can see in this green shape, the dura opening. And in this case, it's an obtuse angle. I'm going to go back and stop. And as you can see, there is no clear rectus angle. There's no 90 degrees angle. It's maybe 60 degrees. So in this case, we open the dura in star shape, like we show. And also, that small space is enough to go to the contour angle. As you can see, we never use retractor. It's not necessary in this position, only with the liquid drainage. I will show some examples. In this case, it's a right trigeminal neuralgia. It's very easy to go to the anatomical area described before. You can see clearly how is the vascular contact and application of the Teflon. And one point, I guess this is an old video taken from me and my college, but in the present, in the last years, we prefer use less Teflon and to put away from the nerve. In the last decades, 2 decades, we have found a couple of granulomas. It's a long time complication after the Teflon is invaded for the fibrosis. So up to date, we prefer also the same material, but collocate just from away to the nerve. And this is a review. We call this in 180 degrees to the right and 180 degrees to the left. It's impossible to do it. This is the TC. It's impossible to do the revision 360 degrees. It's just technical note. And in this case, as you can see, this is a patient with morbid obesity, more than 40% of overweight. And I want to show this. That's why the picture. Just the adipose panicle was about 4 centimeters, 1 1.5 inch. Sometimes the instrument is not enough or can complicate the surgery. After that adipose area, of course, there is another region, the bone region. It could be also 1 up to 2 centimeters. And in the pontocerebellar angle, it's very easy to treat the vascular element. In this case, we collocate the T-flum, and it seems to be easy, but it's not. Next sample. I want to emphasize because a friend of us is looking from Spain and has from many cases from multiple sclerosis and trigeminal neuralgia. Of course, is very known for us neurosurgeon working in the skull base and working on trigeminal neuralgia and with experience. But for most of the general neurosurgeons, for neurologists, for alveologists, for ontologists, they don't know that the half of the patients with multiple sclerosis have a vascular compression. Of course, as you can see in the video, there is a demyelinization, there is an atrophy from the nerve in this area, and you can see we are removing. Also, this is a normal arachnoiditis, like a viscous. You can see the nerve looks like fillets, very separate between them. There is no surgery before. There was no gamma knife before. And beside that, of course, the patient have vascular compression. It was removed. Another example, also is very common for us. In Mexico and Latin America, we can do this surgery very common. Patient with more than 70 years old. 20% of cases have more than 70 years. And in US, it's a criteria for not operation or for not to go to the operation room according to the American guidelines. However, for us, it's a simple surgery. It's very easy. There is a long, huge space, cisternal space. You can see the nerve cistern segment. This patient have complex vascular compression, multiple vascular, venous, and arterial, and she was operated a couple of weeks ago. And of course, you need a very intrepid anesthesiologist and technology to do the monitoring and also to avoid or to take care for another comorbidities as diabetes, cardiopathy, hypertension, for example. And finally, one more example we see in the previous presentation, patient with vertebrovascular dolichoectasia is not so rare. We have dozens of patients with this situation. As you can see, this is the nerve clearly compressed. For this is the, again, sorry, right side. This is upper side. This is the superior cerebral artery, and this is the T-flum. But after that, we are going to treat the vertebrovascular dolichoectasia. In this, I will stop. Here is the trigeminal nerve. In the first step, we separate the supracerebral artery, and here we are doing the sling technique or proposed by Dr. Morcos. This is latex, and we are going to put some clip. We are remodeling. It's called the transposition of the vertebrovascular complex, and collocate a clip. In this case, was a couple of clips in the petrous bone here. And we stop because it's important You remove this, you transpose here, you can look this space. The nerve, the basilar artery, and after the remodeling, we are going to obtain a free space here. And stop. Here is a free space without contact from the peripheral basilar artery. This patient was delivered yesterday. This patient is a young man with a expectative life, maybe 3, 4, 5 decades. So we don't want he come back shortly. Another clip. And after that, we are going to protect the clips. Of course, mini clips looks young, but it's a very careful surgery, less than 2 centimeters. You can see the space. And the day after, the patient was completely free of pain. A little TC, and this is the approach. 2 centimeters is important. We never, I want to say clearly, we never do this surgery without all the elements. Midas, it's very important. Drills, microscope, clips, Mackenzie, many micro scissor, many bipolar. Incluso, we are doing a modified capa bianca in order to reach some deep veins. And after that, the closure is the same as we know. As conclusion, but not my conclusion, but recommendation in this case, in my country in Latin America, of course, if we have another opportunity in the future, we can talk about the result, the outcome. We are working with the Professor Campero, Professor Matías, with a follow-up in this with all patients in these countries. Approximate up to date 5% of recurrence in a long time, not in the short time, but in the long time. I'm talking about almost 1 decade. Surgical management of trigeminal neuralgia, it's matter of the high-level neurosurgical center. It's not for resident, it's not for first, second degree resident, it's not for the last time schedule in the operating room surgery. It's as much important as meningioma, as aneurysma, as another brain surgery. Thank you very much.
Thank you, Professor. We are running of our time. Could you answer the questions in the message box? Maybe we can continue with the next speaker, John Lee. If you could, you can answer messages from message box. We will continue with John Lee. Please, Professor Lee. Maybe you can write as a message, or so everybody can read. Professor Segura.
Yeah, but I don't see the.
Okay, after the session, we can ask again. We will continue with the John Lee. Please, Professor, you can start. We couldn't hear you.
Can you hear me now?
Yes.
Okay.
Perfect.
Sorry about that. Okay, so thank you so much to the WFNS and the course moderators and our brilliant speakers ahead of me and after me. Today I'd just like to talk about a topic that I've been doing for quite a while, which is endoscopic microvascular decompression. I practice at Pennsylvania Hospital, which is the first hospital in America. You can see the front here, 1751. But I want to call your attention to the top. Look at the ceiling or at the roof. And at the roof, you see this beautiful kind of circular thing. Now you'll see there's windows there, and there's going to be beautiful lights. And the reason is that the first surgical amphitheater was housed there. And this gas light was only started in the 1830s, because before that, it was only all natural light. So surgery can only be done when there's high noon and very, very bright light. And so my point is that surgery, you need light. It's the story of light. We need to bring light into the field. And that's where the endoscope has tremendous value. Of course, having trained at the University of Pittsburgh as a resident, when I first got there, Haedong Jo was my faculty mentor. And he had just published his series of 50 pituitary endoscopic adenomas in 1996 with Ricardo Corral. And he told me this crazy story. He tried to publish this in Neurosurgery, got rejected, tried to publish this in Journal of Neurosurgery, and that got rejected. And so finally, he could only publish it in an ENT journal. And that's the birth of endoscopic and the nasal surgery. So when I got there in 98 as a resident, he was already using the endoscope for many other conditions. As you know, he was a foreign fellow with Peter Janetta, and he stayed on as faculty and was doing lots of MVDs with Peter. But of course, we do a lot with the endoscope, but why not in the CP angle? This is a paper I was proud to be part of, the BRAF identification story. So I've done a lot with endonasal, but what about CP angle? And so is there a role for the endoscope in the CP angle? And that's what I started to explore. Now, Dr. Jo was already doing this when I got there. He was doing endoscopic MVDs, although that was not the majority of his practice, because PJ was still doing, he would run 3 rooms of MVD surgeries, and usually 2 or 3 MVDs in each room, and he was still doing with the microscope. So when I first learned, it's with the microscope standard. We would do 1 perforator burr hole kind of far out lateral, and then use a Kerrison and Lexel. That was the only way we were allowed to do it. So I think he did that so that it would keep us slower, because Janetta had to run from 3 rooms, 1 room to the third, every room. And so the junior resident takes a long time just using hand tools to get to the sigmoid transverse junction. Of course, now we do it much easier with different matchstick burrs and others. So is there a role for endoscope? So Dr. Jo, he was already doing this when I got there. And there were other people who were practicing it and experimenting with it. I also think that the retrosigmoid is such a versatile approach. And this is Jacques Morcos's talk. I love this, where he shows, based on the cranial nerve and the brainstem, where you can get an RS, which is shown in blue, can get you everywhere. And especially if now we can introduce the endoscope with angles, maybe we can tackle a very diverse pathology in addition to the MVD. So these are some of my mentors, Dr. Janetta, Dr. Haedong Jo, and then actually to the far left, I just want to point to Charles Harrison Fraser. So I moved from Pittsburgh to Philadelphia, which is in the same state of Pennsylvania, and Charles Harrison Fraser, it was the chairman where I am now, and he had a very long history of trigeminal neuralgia surgery also. He, with Harvey Cushing, would do the subtemporal retrogasserian rhizotomy, and so I feel like I've been engrossed in trigeminal neuralgia my entire career, from residency training starting in 98 to now 2024. So back then, I just looked at the literature, and Dr. Shahinian, who many of you may be familiar, was doing endoscopic MVDs as well. The late Dan Piper was also one of my colleagues and doing a great job with this. There was many people introducing endoscopes into the CP angle, but I really credit a lot of people ahead of me for doing this. I also think, as I mentioned, there's the suprameatal approach, which gives us access to the Gasserian ganglion. So there's a lot of value in retrosigmoid approach. Even though it's quick, fast, you can also cut the tentorium, get supratentorial access to the ventral midbrain, the third nerve region. So I think that there's a lot of value to exploring how we can make the endoscopic or the retrosigmoid even more versatile than it already is. So now, for trigeminal neuralgia specifically, I'm glad Dr. Segura said something that I also agree with, which is that the diagnosis of trigeminal neuralgia is clinical, in my opinion. It's taking a careful patient history. A lot of important features you want to hear: sharpshooting, lightning bolt pain. You want to hear that they have a very memorable onset. They can remember, many patients can remember, oh yeah, I remember when I first had that pain and it was terrible. It needs to just be that sharp shooting pain. Now you can have a mixture, but if you don't, I always say, if you have a mixture of the constant burning there all the time, but you have sharp shooting, if I only take away the sharp shooting, would that be sufficient to warrant doing this surgery? So that's a question I always pose to my patients with mixed or the Brachial type 2, for example, trigeminal neuralgia. I always like to see that they have some improvement with antiepileptics, because if you have no improvement and you're only using narcotics, I mean, this is not gonna, I'm not gonna recommend surgery. I probably see 7 to 10 patients with facial pain every Monday in my clinic. I see about 50 patients during the Monday clinic. And during that time, I might only operate on 2 or 3 a week, just because most of these patients are atypical, or I don't think they're going to get better. But I also will offer some gamma knife and some radiofrequency, especially for MS patients. Now, what about then? What is the role of the MRI? I'm very much against these headache societies now have said that trigeminal neuralgia can only be diagnosed if you have vascular compression on MRI. We published a paper which showed that our radiologists don't know what they're looking for, and most of the time they don't even comment on this. And so even though the report is negative, they clearly have vascular compression. Another thing is Kim Birchall did his very detailed analysis where everybody got the same stereotactic sequences, and then he took them to the operating room. The negative predictive value is only 30%. So if you don't see something on MRI, you still will see something 70% of the time in the operating room. And we all know that because we go there with the microscope, with the endoscope, we can see much better. So how do I position my patients? Actually, this is an old slide. This is how I used to do it with Mayfield head pins. Actually, now I don't use any Mayfield head pins. I do everything I just put them in a horseshoe and a pillow, and then just tape their head down. So this is, I continue to evolve my technique to become less and less invasive because these patients have pain. I don't want to give them more pain to do the surgery. So no more head pins. I still do use the Mitaka endoscope holder for every case. I did 17 cases. When I was young faculty, I obviously did it with the microscope, but I'll show my transition. But now everything is endoscope. So I don't use the micromanipulator anymore. I just simply use my hands, use the pneumatic. The instruments have to be a little bit different because you want single shaft instruments. You don't want the standard bipolar, although I still use those. What I'll do is I'll pull the endoscope back, put the bipolar down if I need it, and then bring it back. So here's my technique. I just clamp on the Mitaka to the edge of the bed and then make this figure 4 and then bring the endoscope over. Although now I do the first joint over the incision, not the second joint. So here's a picture of that. This is a 2.7 millimeter outer diameter scope. I don't use this this manipulator anymore. It's a Storz. I use this offset. I think mostly just because of weight balance. It was just what I started with, and I still do. I use the Fukushima suctions, the late Dr. Fukushima, and that's the standard technique for MVD surgery. So I do the same opening that most all of us do. I have seen lots of differences. I'll do a linear incision. And then, so this is a picture of how I do it now. I just position them on the bed and tape their head down. Our modern anesthesia is so good. Actually, one of the reasons I switched to moving away from the Mayfield head clamp is I do all the acoustics for pen. So I do about 1 a week. And I used to do them all retrosig with a head pin, but started doing lots of translabs, and I've shifted a lot of practice to translab. And translab, we don't put ever any pins, and the patient does fine. And we have perfect relaxation, patient's not moving. As long as you yell at anesthesia enough, you can get them to not move. And so recognize that we don't need to pin. I think we pin more because of history or maybe for navigation. Again, I don't use navigation. So in this case, I don't need pinning. So this is my technique as of 2020. I don't do usually a cranial. This takes longer and it's more challenging. So this was with the Sonopet bone scalpel. But really, what I do is just drill away like everyone else. Most important thing, and Dr. Segura talked about this, is get to that sigmoid transverse junction. But I actually find that as long as I see the sigmoid, it's nice to see the transverse, to see that 60-degree curve, like as he mentioned. But actually, as long as I see the sigmoid and it's sufficiently high, I'll be fine. I can come in a little bit lower. I can come in a little bit higher. It's easier if I'm at the sigmoid transverse junction with the tentorium, but either way works fine for me. So this is my standard opening. It's a 1 centimeter opening in the dura, and this provides plenty and sufficient access. I always emphasize a triangle. You have to keep. I keep my endoscope high along the petrous bone and the dural opening, and then I keep my hands under. And this reinforces. This way, when you bring your hands in, you know exactly where you are. You don't have to bring the endoscope out and then bring it back in. In the beginning, I had to do that because I'm young, I'm learning. But now, after 1,000 of these, I'm able to just bring my hands in as long as I keep that orientation proper. So this is that technique. And is this a video? Okay, these I think you were all familiar with the anatomy. Dr. Baldoncini presented this earlier. You get fantastic views. That's glossopharyngeal neuralgia. This is hemifacial spasm. Oh, hemifacial spasm is a great case because this is the view with his the hemifacial spasm is the best case to use the angled scope. And what I find is that I start with a 0 for trigeminal and for glossopharyngeal, but for hemifacial spasm, I start with a 0. And then it's very useful to switch to a 30-degree angle to the brainstem. And in that way, I don't have to take down all the arachnoid over 9, 10, 11. I don't have to, and then I try to keep every case, I try to keep the arachnoid intact over 8. So that if I stretch a little bit, it's pulling on arachnoid and not necessarily on the cochlear nerve itself. So that's a unique thing. Oh, the other thing too is when I started with this with Peter Janetta, we started always at 9, 10, 11. We dissected all the arachnoid all the way up from 9, 10, 11 over 7, 8, and then to 5. But part of that was also because he was doing the hypertension and diabetes, MVD decompressions. But that was my classic technique I learned with a microscope. However, now I'm just very direct. I just go straight to the 5th nerve. I don't even look at 9, 10, 11. I just know where 8 is because it's the first nerve. I don't take down any arachnoid over 8. For trigeminal, I just go straight to 5. And I try to avoid taking any petrosal veins. The petrosal veins and its tributaries are very critical. I think that even though you get away with it almost all the time, that 0.1% of the time where you don't get away with it, you're going to have a disaster. So in general, I try not to touch the petrosal veins. This is cutting nervus intermedia. Sometimes I try to do this for a deep ear pain, geniculate neuralgia. I don't need this anymore. In the beginning, I needed all kinds of special. I felt like I needed special bipolars, like the EndoPen today might be the best option. We published this original series and this technique guide. This is 11 years ago, doing it fully endoscopically. This is maybe a video, just a kind of a classic. As you can see, the classic SCA. I just said I'm not taking the petrosal veins, and here I am taking one, so I apologize. Every once in a while, you do have to take it. Actually, probably today I wouldn't take this one, but here it is taking it. And then I'll just speed this along, and we'll put the Teflon in. I agree with the point about not too much Teflon because I have seen Teflon granulomas because I'm in Pennsylvania in the region where Janetta was working. I've seen several that, and I think when you pack too much, that's never good. And then today, I think it's important. I should look more distantly and try to get that a little bit more decompressed, and I'll work on that. And then I'll also decompress this vein while I'm here. So, and there's the 6th nerve. So there's a lot to, yeah. So you can see I packed a little bit more in there. So this is more than 2 years ago, not as quite as much experience as Dr. Segura, microscope, endoscope only. In this example, about 600 of them. And very similarly, mostly trigeminal neuralgia in the United States or in the East. I know that when I present in Asia, I'm Korean heritage. My Korean and Japanese colleagues have many more hemifacial spasms than me. So I'm also doing acoustics as well. This is a picture of Charles Harrison Fraser, he was very proud of this number of surgeries he had done for tic douloureux, and I'm going to Photoshop my head on his face when I reach his numbers. So we've published our comparison paper, and the main conclusion from this paper is not necessarily that the trigeminal neuralgia outcomes were any different, but rather that our facial pain, our postoperative headache risk was lower. And that's, I think, significant. 21% complaining of post-op headache with a microscope and 7% with the endoscope. So that, I think, is a very important part. Distal decompression. One beautiful advantage of the endoscope is that you can see much more distally, as shown by all the our anatomy colleagues. With the microscope, you're constrained in what you can see. You can't see way out into how the nerve goes into the tubercle, into Meckel's cave, and that suprameatal tubercle can block you. The endoscope provides much better decompression. Now, how do I do the surgery? I park it, I suction out all the CSF, but sometimes you, when you're trying to look around corners, you only have one hand. You have the endoscope hand, and then you have your instrument hand. Sometimes you have to let the CSF well up and then do it like almost like ventriculoscopy. And I know there have been publications on this, which is fantastic because sometimes you have to resort to that. But then, of course, if you get a drop of blood, then you can't see anything, or a few drops of blood. So if you have distal vein only, we had in our multivariate analysis, they didn't do as well as if you have artery and a distal vein. And then, of course, young patients don't do as well. So the etiology of their pain is probably not as typical trigeminal neuralgia. I've done this in children. I've gone to the Children's Hospital to do it, but I don't think their results are as good. This is just talking about distal decompression, and yeah, it's just working out there. So nuances, I have so condensation. So with the endoscope, the problem is you always get condensation on your lens. So here you can see it building up. And then what I do is I bring my suction out, bring in the cold air, and then so this is one of the challenges. You don't have this problem at all with a microscope, but you try to use a lens fogger, and then eventually you learn how to work with it and do better. The Petrus tubercle, as we mentioned, can be a problem. So here, it's hard to see the distal. You can see the proximal. How come every video I'm taking the petrosal in this one? I'm so sorry. I try not to. But yeah, it's very hard to see over here. So what we'll do is you can look around. Sometimes I'll do the one-handed, although I don't think I have a video of that here. We've done this also, obviously, for hemifacial spasm. Hemifacial, I open a little bigger than with trigeminal, just because I do want to make sure I have a little bit more access inferiorly and superiorly than compared to trigeminal. Just the surgery, I find, just is technically a little bit more challenging with hemifacial, because you're also much more worried about the eighth nerve, and you get more of the the brainstem auditory evoked response changes. So here's another heavy facial view. This is the 30-degree looking in. So here is a standard 0-degree view. It's very hard to see. I'm just kind of dissecting here, just taking a look, retract a little bit on my eighth nerve, and then trying to understand where that artery is going. Yeah. And then the view with the 0 is somewhat limiting. So the nice thing is when I put the 30-degree down, angled medially, then you just get a much better appreciation and view of what you need to decompress right there. And then it becomes much better to appreciate, do the surgery. And then so I just park the 30 and then carefully lift that up, carefully avoid injury to any perforators, and then bring my Teflon in. And then you can see there, I didn't bring the endoscope in and out. I don't have enough hands to do that. And so what I'm just doing there is just remembering my hand position, my psychomotor, just know where your hands are, and then carefully bring your instruments in without crisscrossing or causing a problem. So that's that. We published our experience with fully endoscopic hemifacial spasm. I still find the lateral spread useful. It's not a perfect test, but I think it gives me just a little bit more information about what's going on. Here's a typical bone opening for my cases where I you see that little rim there of no bone wax, that's the bone wax. and then I fill it with the bone putty afterwards. So that's a typical MVD exposure. This is in the old days when I used a titanium plate or just a burr hole cap to put that over. I don't do that anymore. I sometimes get these patients as redos from an outside institution. This is a local institution to me in Pennsylvania, and this is the chairman of neurosurgery there doing an MVD, and this is the opening he did. I assume this was the resident who did this, and not the chairman. And then, of course, there's tumor work, but I'm going to skip that because this is focused on MVDs. So thank you so much. I look forward to any questions.
Thank you, Professor, for this excellent presentation. I think at the end of the session, somebody will ask some questions, and we will continue with the Professor Oliveira. Professor, you can share your screen.
Please.
Yes, we can see your slide. You can continue.
For me to participate in this international symposium, I'm here in city of São Paulo. We will share the experience in pain and thoracic center of AC Camargo Cancer Center and Functional Neurosurgery Unit, Hospital dos Servidores Públicos do Estado de São Paulo. Also, think that the percutaneous techniques for the treatment of trigeminal neuralgia that we adopt in our practice it is important that we define the disease that we try to mitigate with percutaneous techniques. We will adopt the clinical classification of trigeminal neuralgia, typical, secondary, or primary. According to the pain field complaint and the pain territory, trigeminal somatotropy allows choosing therapeutic targets in peripheral nervous ganglia or structures of the central nervous system. Relief procedures in which we preserve the system are called non-ablative. When purposely damaged the peripheral or central nervous system, we are performing an ablative procedure. Three situations are possible: insufficient injury and previous pain remains. The injury in the right amount balanced and analgesia obtained, or too intense injury and worsening pain. transformation into a typical neuropathic pain with a worse prognosis for control and iatrogenic pain. Start with the procedure performed on peripheral nerves. Anesthetic blocks are useful as diagnostic test, therapeutic test, and a simulation prior to the use of a neurolytic agent. They can be done just once or serially, repeatedly. They can be guided by imaging exams or freehand. The most commonly used drugs are lidocaine, bupivacaine, with or without addition of sodium bicarbonate, with or without vasoconstrictor, with or without corticosteroids. When the procedure is ablative, corticosteroid, alcohol, phenol, MN, and miglobin are the most chosen neurolytic agents. Botulinum toxin may also be beneficial. Function of convention, pulsed or randomized radiofrequency to a peripheral branch of the trigeminal, such as the infraorbital, can be very useful. The results may be more ephemeral in pulsed and randomized application through auto complication rate with this form are very low. Mental and mandibular nerves are useful for third division neuralgia. Access to the trigeminal ganglia was described more than a century ago by Hartel with 3 anatomic points. The first one that defines the insertion site of cannula is a lateral distance from the angle of the mouth between 25 and 30 millimeters. The second is 1 millimeter medial from the center of pupil on the lower edge of the orbit. The third defines a coronal plane 30 millimeters anterior to the tragus. Anesthetic infiltration is performed at the point lateral to the angle of the mouth. After 2 to 5 minutes, depending on the type of anesthetic used, we puncture the skin towards the other 2 landmarks. After the passage of the hard palate, we may find it difficult to penetrate the foramen. For many years, neurosurgeons around the world were able to perform procedures by assessing the oval hole only with the variable assistance of Hartel points. In effect, some foramina are particularly difficult to puncture. The submental view with slight rotation to the opposite side to the pain allowed direct visualization of foramen and reduce difficulties in identification and puncture. We use this parameter to find the correct localization. Here we see the surgical times with the monitoring of lateral endoscopic and local anesthesia. The puncture of the skin and the index finger palping the inner surface of oral cavity to avoid needle penetration and possible contamination and bleeding. Then in-depth progression of the cannula to the base of temporalis bone, changing from the profile to the submental vertex view for identification and consequent puncture of the foramen. On the left, we see a direct view of the foramen in lower drawing and above the foramen already puncture with the fine needle. On the right, we see the foramen puncture by thicker cannula. Thicker inside once inside the foramen, how deep the cannula is the question. There is a need for a lateral radiography view. The clival line is a good parameter of depth and safety. The bone offers additional lines polluting the image. The bone offers additional lines polluting the image. In profile, the clivus line fits the posterior aspect of posterior clinoid. The risk increases then the tip of the needle is about 5 millimeters behind the clival line. Neuralgia of the second division of trigeminal deserve extra attention as the fibers are located more caudal and medial than the other fibers. Lateral puncture favors the angle to reach the fibers of the second division that are medially located. When the electrode offers distal curve, difficulties usually disappear. Chemical neurotomy of the trigeminal ganglia can also be done by percutaneous puncture of the oval hole. We identify the foramen oval. We wait for the cerebral spinal fluid to come out. We place the patient in semi-sitting position with neck and head flexion. We inject contrast in fractional manner with a liquid of 0.1 milliliters into the trigeminal system. After visualizing the system, we wait for the contrast to drain and then inject the same volume of neurolytic agent. We keep the patient in a semi-sitting position for 2 hours. Puncture of a foramen with a large cannula allows the passage of an embolectomy catheter into the ganglion. Once in position, we inflate the balloon with contrast for 75 seconds. During this period, the pressure within the ganglion reaches values higher than the blood pressure, which results in ablation due to ischemia. So we performed in general under general anesthesia. On the left, identification of the foramen, puncture with the radiofrequency electrode in the middle, and with a cannula with the balloon on the right side. We see a short video with one micro compression of trigeminal. We have complication of percutaneous trigeminal ganglia procedures. Early, intraoperative, postoperative, and a smaller list with minor complication. Trigeminal nucleotractomy can make with percutaneous way, a stereotactic percutaneous way. But this kind of procedure has vascular complications, such as bleeding and vasospasm, that do not occur in the open procedure. So we don't do any anymore percutaneous for stereotactic trigeminal nucleotomy. Acupuncture, electroacupuncture develops progressively shorter periods as time passes. So I don't have experience. And stellate ganglion block is useful for postherpetic trigeminal neuralgia, and it's very important to perform in ambulatorial setting. Mesotherapy with vincristine or similar is similar to chemical dress. It's very interesting. Thank you all for the attention.
I would like to thank Professor Oliveira. We are out of our time. Most of the questions answered from the lectures, and I want to thank all lecturers. This is a summary of all treatments. We listened from the experienced surgeons, and also for the neuroanatomy lectures. I want to give a special thanks to Matías. And Professor Zilali, do you want to add anything?
Yeah, actually, probably some speakers may answer the questions already answered by written.
Yes.
We can have some time for discussion.
Okay, and I think for radiofrequency ablation, what is the best parameters for pulse radiofrequency and thalamic lesions in trigeminal neuralgia. I think this is for Professor Oliveira.
For radio frequency, we do lesions about 7 and 75 degrees for 30 seconds or 1 minute, and made examination for the sensibility. The patient is under light sedation and made collaboration during the procedure, and during the microcompression is under general anesthesia, and we do the compression about 75 seconds, and if the deformation is good, if and the pressure also is good. If the modification of silhouette of balloon it isn't good, we change the localization. But it's very interesting because we do not do radio frequency for first division, only second division and third division, because complication of corneal sensibility.
Okay. I have one question to Dr. Matías and Dr. John Lee. It was said that the recurrence rate after microvascular decompression, either with microscope or endoscope, is very low. But as I know, it's not that much low. Probably in not very experienced hands, it is quite high. What do you think about that? Actually,
that's an excellent question. And so I went back to Fred Barker's paper. That's that classic 1996 New England Journal paper published by Fred Barker when he was a fellow, kind of observing Peter Janetta. So he came from Mass General. He went to work with Peter Janetta. He opened up all the charts, called all the patients, and Fred's genius at that time was that he knew statistics. He knew how to do an actuarial curve. Now today, so easy. Just put it into computer, 5 seconds, you have the answer. But when you go back to that paper, he specifically says that the definition of recurrence was not any pain. It was only sharp shooting lightning bolt pain. So patients can, so he made his own definition of what is considered recurrence. Now, if you ask patients though, they have all kinds of experiences. And so that has been my experience. Patients will come back, but their pain has changed. It's not always the same sharp lightning bolt again, but now they have, oh, now Dr. Lee, it's on this, it was here, but now it's here, now it's here, and then and so that's number one. So I think you have to be careful because I prepare the patients very carefully, like this is only, now there are still also, as you know, the patients who come back with the classic trigeminal neuralgia. And that's where it gets more complicated, what procedure to offer next, because in general, you feel, what am I going to do the second time when I go into the surgery? But I agree with you. The treatment of pain is so difficult because definitions are hard to establish. Who's going to get better is hard to establish. So that's a great question.
What about that? We used to say in the past that the microvascular decompression is better in the younger ages, but in the older patients, you can make RF lesions or rhizotomies.
It's a good question. The
now,
surgery, the microvascular decompression.
You try to say the controversy.
Yeah, no, actually, as you know, MVD is easier in the older patient because the brain is so slack. So I actually think, but you're right. If I see somebody who looks like my mother and she's like 80 years old, I just say, we're going to do gamma knife or we're going to do radio frequency. I'm not going to rush to surgery. But
Hi, Professor Emmett.
Yes.
Also,
Hi.
I think completely 100% agree with Dr. Lee. But the matter is that we cannot compare everything with everything. It's easier for a high specialized center to do a microvascular decompression with the high quality as Dr. Lee showed, Dr. Matías showed. But for a young surgeon, for the first 10 years, learning curve, neurosurgeon, even skull-based surgeon, but the first, second, third, it's not easy to compare. And I don't know how much is too much or too less, but in the last revision from European neurologists, 2016, was less than 10%. It's too much. For us, too much. In our revision was 5%. I think it's not too much, but it's difficult to do a comparison. Also, in the European Neurosurgical Society, my young German doctor, he compared but 10 center, different center. It's not easy to compare 20 hands. So I think it's a very hard work we have to do in this academic work to define of course, the topic, recurrence in trigeminal neuralgia, which center, which surgeon, and which data we are going to review in 2 or 3 bleeding. Doctor Matías, un estudio 2 o 3 triple ciego, no sé. That's all.
And I saw that Dr. John Lee has said in recurrence, if it is his own recurrence, then he's sending the patient to gamma knife or radio frequency lesion. Is it right?
Yeah, so I know what I did with surgery, and I have video recording, and I can see. I doubt there's much that I can decompress more. So it's rare that I do a redo surgery, but so I will send them. But then the problem is, then they might get relief for 2-3 years, and then the pain comes back, and then the third time, if I might have to do a repeat MBD. But I don't do a lot of my own repeat MBDs. But that's maybe they're going to another surgeon and going to some other surgeon. It's possible.
Okay. Yes, Abuzer, we can finish, I think.
I think Matías.
Yes, please.
Yeah, 1 minute, no more. Completely agree with Professor John Lee and Mauro, and that's why I think that it's very important to record our surgeries, because if we, as Professor John Lee operates 3, 4, or 5 cases every single week, it's important to say, okay, if the patient comes again to the medical consultation with pain, it's important to review the surgery in order to remember if I was able to observe the length or the complete length of the nerve, if the microvascular decompression was easy, etc. It's important to have the surgeries recorded. And I think that at least in our cases, if the pain is present for a long time, it's important to remember that it's a nerve, and when the nerve suffer an injury, in this case a vascular compression injury, For some months, this lesion will be an acute lesion, but if the patient have a trigeminal neuralgia during years, like some cases, this patient will have a chronic neuropathy in this nerve. And maybe we can perform a beautiful surgery, beautiful neurovascular decompression, but the nerve still with this injury in its fibers of the nerve. That's important to keep in mind. If a patient, and that's why I think that's very, very important to be in close relation and in continuing teaching with our neurologists of our department in order to remember that the diagnosis is with the clinic. If the patient have this classic facial pain, it's important to offer to the patient the real treatment, that is the surgery, and not to give medical treatment as a first option.
What's your comment on, in the past, I heard that if there is no significant vascular compression, then you can make some injury to the nerve during surgery. Is it still applicable? Are you still doing this similar thing?
Yeah, so when I was with Dr. Janetta, he would never intentionally injure the nerve, but I could see he was very aggressive with moving the nerve and packing it, and all that movement, I think, causes some injury. And then I listened to a talk, but I'm hesitant to do that because I don't want to give anybody anesthesia dolorosa ever. That was like so terrible. So then I listened to a talk by Kim Burchell, and he described just taking your round knife and just make a linear parallel to the nerve. Some Chinese author call it combing the nerve. So now I will do that. If I don't see, like, I'm not convinced that compression is very dramatic, but I know they have classic trigeminal neuralgia, I will do this. I call it neurolysis. And so now I'm coding that in my results to see if that makes a difference in their outcomes. I still have not yet seen that in my data, but that's the way I do it. But maybe we hear from Dr. Segura, Dr. Baldoncini.
Thank you for clarifying this. Thank you.
I have opinion also. It's very, very rare, maybe less than 1% that there was no compression. Of course, we have to look for in the bottom, in the how could say, sometimes it's necessary to drill the suprametal tuberculum, and the compression is surrounding the trigeminal nerve in the entrance to the Meckel cave. After 1 centimeter bone removal, and sometimes one vein is just behind the nerve, close to the pons, and sometimes innominate vein is crossing, very small, but it's surrounded by arachnoiditis. So it's very rare. However, I do not prefer, never use the combing techniques, because not ever the combing technique and also the neuropraxia, because the consequences is worse than the pain according to the patient. In that case, less than 1%, we prefer to do the radiofrequency, retrogasserian radiofrequency, like a pulsed technique, 45 degrees, 1 minute, and we have a good result. Of course, we need a long-time outcome.
Decompression is a great therapeutic option and also a great teaching tool for residents and fellows. As long as the patient is clinically fit, this compression is one of the methods presented that comes closest to treating the cause. Percutaneous methods are also very useful, but must be done with caution, so as not to cause atypical pain. think that is a very good tool to teach micro neurosurgery.
Okay. I think we can close session, Abuzer.
Yes, we can close, and also we shared our YouTube channel and the Facebook accounts. You can follow us, and also you can watch again these webinars. I want to thank all lecturers and the audience to join us today. Thank you again. We're closing our session.
Thank you, everybody. Goodbye.
Bye.
Goodbye.